My name is Jordan Applegate, and this is my patient presentation for Mn568. Today in the clinic, we had Cassie Fisher, a 52-year-old African-American female who was seen in the clinic for a chief complaint of terrible pain in her abdomen. She complains of right upper quadrant and right middle quadrant abdominal pain that started about a week ago. She says the pain is mostly in the middle and right side of her stomach, and it is a constant, sharp, and stabbing pain for the last 24 hours. She said it gets worse as time goes by and has not noticed any specific foods that make it worse. She has tried Advil for treatment, which seemed to help a little bit but did not eliminate the pain. She reports that the pain is getting worse as the week goes on and is a 7 out of 10 pain. Her medication list includes simvastatin for hyperlipidemia, glyburide and metformin for type 2 diabetes, lithium and quetiapine for bipolar disorder, and she denies any allergies or medication intolerances. Her past medical history includes type 2 diabetes, hyperlipidemia, and bipolar disorder. Previous hospitalizations and surgeries include a hysterectomy, 2 C-sections, and an appendectomy. Pertinent family history includes her mother's diagnosis of diabetes and hypertension, and her father, who has passed away from lung cancer 5 years ago and was a smoker. Cassie has been a smoker for 32 years and says she smokes a pack a day with no interest of quitting. She denies drinking alcohol, but in her past has used marijuana and cocaine, but that was 15 years ago. Her vital signs were stable and within normal limits. Of note, her BMI was 29.3, which is classified as overweight, and her blood pressure was mildly elevated to 138/84. During her review of systems, she denied any pertinent changes or concerns. She reported right upper quadrant and epigastric pain. She said she had a bout of vomiting a day and a half ago, but denies any heartburn, diarrhea, or constipation. Her abdominal assessment presented with involuntary guarding and with moderate tenderness to palpation in the right upper quadrant and epigastric area. There is a positive Murphy sign upon palpation of the abdomen. Pertinent lab tests that we conducted were a CBC, CMP, lipase, and an abdominal ultrasound. All lab results resulted and were within normal limits. The abdominal ultrasound was positive for gallbladder wall thickening and gallstones. The abdominal ultrasound and positive Murphy sign was diagnostic for acute cholecystitis. We were able to rule out peptic ulcer disease, GERD, and acute pancreatitis based on her gallbladder wall thickening and presence of gallstones. The presence of a positive Murphy sign is suggestive of acute cholecystitis, which is inflammation of the gallbladder. Cassie's plan of care includes an antiemetic like Zofran, 4 milligrams orally every 8 hours as needed, and a potent NSAID, ketorolac, an initial dose of 20 milligrams, followed by a 10 milligram dose every 4 to 6 hours as needed orally. Non-pharmacological interventions include avoiding foods that are fatty, greasy, or acidic. More than likely, Cassie will need surgical intervention of the gallbladder to prevent the recurring inflammatory responses. She was given a referral to a gastroenterologist to discuss the potential for surgery. She should follow up in 1 to 2 weeks in the clinic if her medications are not providing sufficient symptom relief, and 2 weeks after gallbladder removal. At this follow-up, we will also reassess her medication adherence to her diabetes and hyperlipidemia medications, as well as lifestyle changes and modifications that she has made to lose weight and control her diabetes and hyperlipidemia. That is all.